All right. Hello, welcome everyone. I am Dr. Praveen Raghunathan, and I sit on the National Steering Committee of Doctors for America's Drug Affordability Action Team. I'm a pediatrician and finishing my time here as a chief resident in Pittsburgh, Pennsylvania, and am currently in transition to be a primary care pediatrician in the rural Mississippi Delta. And I am thrilled to be moderating today's Lunch and Learn. Thank you all so much for attending. To please help us get to know our audience, we'd like you to answer two questions. Where are you tuning in from, and whether this is your first event with DFA? All right, so see people are tallying the votes. Outstanding. So we have a really wide geographic distribution here. We have people joining us from the West Coast. It looks like the most from the Midwest. We have some from the South, some from the East Coast, some others, and we have many individuals who have had attended previous DFA events, about 75% of folks, but about a quarter of you, this is your first time joining a Doctors for America event. So we really welcome you and are so excited to have you join us. And so the purpose of our Lunch and Learn series is to provide the 20,000 physicians, medical trainees, and other healthcare professionals in our network with training and opportunities to support their advocacy efforts. Our hope is that it will also provide all of you with an opportunity to connect with others doing health advocacy work that you're interested in participating in. And so I encourage everyone to please send future events to our friends and colleagues, to organizations you know or work with, and to send suggestions for topics or speakers that you'd like to see featured. And we'll be sharing a survey with you at the end to make those suggestions a bit easier. We will be making the recordings and all materials available afterwards. And so to transition now to our session today, Health Legislation 101, and understanding more of the present federal legislative landscape. Today's session is meant to be a background primer for our upcoming advocacy sessions, where we'll be pairing interested clinicians in key states with their senators and representatives to speak to the importance of their members of Congress taking action to ensure robust access to healthcare. Please be on the lookout for a follow-up email from DFA with next steps on how to join the Drug Affordability Action Team and Health for All in advocating on behalf of our patients with policymakers. Currently, we are living through an inflection point in our healthcare system with the COVID-19 pandemic over the past year, showing the cracks in our current system for Americans across the country, especially for our most vulnerable patients and their families, and especially our communities of color. Throughout 2020, we saw the intersectionality with the economy, and while folks did not always lose health insurance coverage as quickly as they lost jobs, we saw the economic implications of not having income and the downstream effects with a reluctance to seek care and reduced ability to pay for healthcare services. I sit on DFA's Drug Affordability Action Team, and over the past year, the challenges have continued to escalate. We recognize efforts on prescription drug costs are such an essential part of where our policymakers need to take action, as roughly over 40% of Americans now report difficulty affording their prescription drugs. Over 20% say it's difficult to pay for food or rent as a result of the cost of prescription drugs. And over 20% of Americans have taken on debt or even filed for bankruptcy as a result of the prescription drug costs over the past year. Congress has taken some steps to help our patients during the pandemic to help alleviate suffering through legislation, including the American Rescue Plan and more. But in order to truly build back better, there must be fundamental change to our entire healthcare system. And policies have been proposed in Congress towards this, including drug pricing negotiation and using the savings from that to enhance Medicare to cover vision, hearing, and dental benefits, or lower the age of eligibility for Medicare, and more. And Doctors for America has helped put the spotlight on these efforts, such as just in the last month with the book club session highlighting Medicare for All and a lot of the actual tangible action steps for us to really push forward here. And so today we will hear from two experts and advocates about some of the current legislative proposals and how we as clinicians can also join these efforts to ensure our patients have access to quality, affordable healthcare. And so first we'll hear from Robert Weissman, who is the president of the consumer advocacy group Public Citizen. Robert is a staunch public interest advocate and activist. Robert will be discussing proposals being considered in Congress to curb the increasing high cost of drugs we prescribe to our patients. And then next we'll hear from Amira Suquira, who is the lead legislative advocate for National Nurses United, the largest union of registered nurses in the United States. She leads federal advocacy, legislative advocacy for the union, working to secure workplace protections for registered nurses and fighting to win Medicare for all, and other health, environmental, and economic policy priorities that would benefit nurses, patients, and working people. She'll be speaking on the ongoing efforts to ensure access to healthcare for all. And so without further ado, we'll go ahead and get started with Robert Weissman. So thank you so much.
Hey, thanks so much, Praveen, and thanks everybody for joining. See if I can get this PowerPoint going here. All right, apologies for that. So it's great to be with you all. I am told that it is difficult to hold the attention of doctors without a PowerPoint unless you have a sparkling personality. So I have a PowerPoint. Amira, I think, may be able to manage it without one, but I think that would work for me. What I wanted to do is talk to you a little bit about drug pricing overall, and then focus in on the solution that's live in the Congress right now that I think a lot of you are going to be advocating for. We have both a real opportunity to win and zero assurance that it's going to happen. So it's really a great time to get engaged, and it's necessary to get engaged because absent that, we're not going to win. So just starting with some background facts and building on some of the overview that that Praveen presented in those top of the conversation notes. Drug pricing in the United States is completely out of control, both by any sort of objective measure of how you might determine what a reasonable price is, and if you compare the US costs to those in other rich countries. So this table looks at just the brand name prices. We do better in generics, but on the brand name prices, you see that US costs are wildly out of line with what's the case in other rich countries. The price gouging matters. In addition to the stats that Praveen was mentioning, almost 30% of Americans don't take their prescriptions because of cost. Either they cut their pills, they skip, or they don't get them at all. So 3 in 10 Americans report not taking their medicines because they're too expensive. So all this talk about how we would never want rationing in the US healthcare system, we have extreme rationing in the healthcare system, both in terms of access to all kinds of care, but especially in the area of pharmaceuticals. All of this is made even more outrageous when you understand that despite the industry's claim to be so cutting edge with its research and development, in fact, it's the US government that drives all basic research and contributes to virtually every new medicine that's put on the market. It doesn't mean the US government paid the most for that R&D, or that we get any rights for it, because that's a special separate question. But almost every medicine that now goes on the market had some meaningful contribution from on the R&D side from the US government. Against this backdrop, it is not at all surprising that people are really worked up about high drug prices. I'm going to show you a few slides. This one is a few years old, prior to Trump taking office. But what's notable here is you can see it, Republicans, even in 2015, at the height of all the talk about repealing the ACA, self-identified Republicans were more concerned with high drug prices than they were with repealing the Affordable Care Act. And overall, of course, the numbers are really remarkable and show really extreme concern about high drug prices. Not a surprise given the objective realities on the ground. People are furious about drug company profiteering. The industry traditionally is the lowest rated among all industries. It's had a little bit of an image buff because of its purported role in providing vaccines. But this is long-term trend that will revert back to norm in coming months and years without question. Not just the people who are worked up about outrageous drug pricing, they support really far-reaching measures to deal with it. So if you can see these numbers, these are really extraordinary. 95% saying they support empowering Medicare to negotiate drug prices. 85% nearly saying they support compulsory licensing, which would enable generic competition for on-patent medicines if they're being charged too much, and other measures. Just to put that, and here you see on the Medicare price negotiation, just to underscore this, not just 95%, half the people say, yeah, we're for that, but it's not enough. Okay, so people really want aggressive measures. And to put that in context, those numbers, only 3/4 of Americans believe that the earth revolves around the sun. So when you get 95% consensus on an issue, you're polling in territory that is almost never seen. There's just as close to national consensus on this issue as there possibly could be. But we haven't had progress in decades. And what's the reason for that? Well, the reason is the political power of big pharma. This is data on their lobbying expenditures. Pharma year over year is always the most heavily lobbying organization or industry in Washington, D.C. This is this current year. Here's what's gone on over the last 25 years or so. You see that pharma just leaps and bounds ahead of all other industries. And that has been successful in stopping any action, which is why, and will continue to be successful to stop any action, to overwhelm this vast public demand for reform unless we engage. So what kinds of things can be done? Well, there's a lot of things that could be done to deal with excessive drug pricing. In our view, the most important of those measures would deal with the monopoly. It's the monopoly that gives the drug companies the power to charge whatever they want. There's primarily patent monopolies, but there are other kinds as well. When we do get generic competition and it's robust, I mean, there's multiple suppliers on the market, we see prices falling 80% or more, sometimes much more. There's a lot of sort of particular ways that we could introduce competition and say when we're going to trigger generic competition, even when products are protected by monopolies or other exclusivities, and some of them are bulleted here, but not worth our getting into because unfortunately these are things that we ought to do, but they're not the things that are on the table for right now. These are other solutions that are separate from dealing with the problem of monopolies. There's all kinds of tax proposals to deal with excessive pricing. We could just have straight up price controls. And of course, the most common sense thing would be to permit Medicare, which is like the which is responsible for something like, I think $1 in $6 spent on pharmaceuticals on the planet. Enable Medicare to negotiate for drug prices. Instead of being a price taker, just accepting whatever the companies charge, actually negotiate prices. Okay, why in the world does Medicare not have that authority right now? The government generally has the ability to negotiate for prices on all kinds of products. I think the government buys all sorts of things, and the core rule of government procurement is you bid something out. You have fair contract bidding, and price is one of the big things you look at. And then the government has got the ability to leverage its buying influence to lower prices. That's not true when it comes to Medicare Part D, however, and that is in large part due to this man, Billy Townsend, who in 2003 was the chair of the House Commerce Committee. He also in 2003 was the chief executive officer of Big Pharma's Trade Association, which as many of you know goes by the acronym of PhRMA. What happened is as the Medicare Part D program was being adopted, he had inserted what became known as the non-interference clause, something that said the government could not involve itself in negotiating prices of the drugs it was about to pay for. Well, after he cut that deal, after he had that provision included, he left Congress and he became head of the trade association, PhRMA. It is one of the most corrupt deals in certainly modern American history, and it's had really lasting effects, costing taxpayers and consumers hundreds of billions of dollars conservatively. So the proposal we're looking at going forward, that's live right now, would be to undo what Billy Townsend did and authorize and require the government to negotiate drug prices. The scheme that moved forward in the last Congress and the House of Representatives is known as H.R. 3. It's the Lower Drug Costs Now Act. These bullets give you the key provisions of what the bill would do. It would give Medicare the authority to negotiate prices. It would say that companies couldn't charge more here for Medicare than they do in countries overseas. And you'll recall from the first slide, that's meaningful because the prices here are so much higher than they are in other countries. And if any company refused to negotiate with the government, there would be severe tax penalties imposed upon them. Now, the version of this bill that passed in the last Congress also then extended those lower prices to the private market and said private insurers would get the same price that the government was able to negotiate. That's really meaningful, but it's going to be lost, unfortunately, going forward. There were and are weaknesses in H.R. 3. There were a lot of things that were on the table that would have made it much weaker that through our advocacy, the collective we's our advocacy, we're able to get eliminated. But even in the version that was voted through, that is sort of the default version for what's going to move forward in this Congress, there are a bunch of weaknesses. The government is not empowered to negotiate the price of all drugs, but just many drugs under this scheme. Prices, if the extent it applies to the private market, only applies to private insurers. If you didn't have insurance, you're the most vulnerable portion of the country, you wouldn't have benefited directly from the lower prices that became the default standard. We should have had in the bill, and still hope to achieve perhaps, stronger penalties for price spikes when companies raise their price year over year for no reason except that they can. And we would have preferred that the mechanism to force companies to negotiate was if they refused to negotiate, that we would authorize generic competition, because as we've seen, that's the best way to lower prices and find out how cheaply things can be made. So those are reforms that could be made, but except perhaps for that price spikes provision, we're not likely to see improvements going forward in the current Congress. That's because of sort of what our pathway ahead is. So as you'll know, in the Senate, we have a small, the Democrats have a small majority in the House, first of all, much smaller than most people realize. And in the Senate, of course, there's a 60 vote requirement to overcome the filibuster. So long as the filibuster as it exists remains in effect. Although there's been some bipartisan support for dealing with drug companies, a lot of bipartisan criticism of drug companies, entirely due to the data that you saw before about how that this is a universal concern. Like Republicans are getting ripped off as badly as Democrats, so everybody's worked up about this. Notwithstanding that, these bills are likely to move forward on a partisan basis. So we're not likely to get the 60 votes possible to move it forward in the Senate. And then the only way, therefore, to get it to move it forward with a 50 vote margin is by including measures on drug pricing in budget reconciliation bills. So I presume that you become somewhat familiar with this budget reconciliation in the course of the last several months. It's an obscure Senate procedure that has now become part of mainstream American politics. Budget reconciliation requires that legislation that's included impact either taxes, government expenses or revenues, so either taxes or expenditures or other ways to achieve governmental savings. Well, the provision about Medicare price negotiation would enable huge governmental savings. The Congressional Budget Office, which decides these things, projects it would save $350 billion over 10 years. So that portion of the bill is certainly eligible for inclusion in budget reconciliation. But the provision of the bill that says, okay, those prices will also be available for private insurers, that's probably not going to be eligible for inclusion in budget reconciliation, although we and others will make an effort to argue that it should be. But we're probably likely to lose that. Because of the close margins in the House and the Senate, it's going to be hard to win improvements, although we're going to push for them along the ways I suggested earlier. But pharma is working really hard to prevent this from happening. They're deploying all of those lobbyists, and they're only going to need to break off, a few members of the Democrats in the House or a single Democratic senator in the Senate, assuming no Republicans come on board with this legislation to succeed. So it's going to be a tough effort to get this thing through. The power of pharma is real and extreme. They've converted themselves into a bipartisan political powerhouse, so they have real reach into the Democratic Party. And we have a really tough fight ahead, which is why it's so important that you all get engaged. And that's true both with senators and members of the House who are going to be wishy-washy or possibly opposed, but also those who are supportive, because we need the people who are supportive and with us to fight to have this included in reconciliation. The president said he supports this, but didn't actually include it in his American Families Plan. The view from the White House is, you guys go ahead and fight it out. If there's support for it, we're for it, but we're not going to expend political capital on it. So it's up to us to get that political capital. The last thing to say is, if we succeed, well, in addition to bringing price relief directly to taxpayers and indirectly in important ways to consumers, we will also have saved $350 billion, which is money that could then be spent on other things, ideally improving and expanding Medicare, which is where I drop off and hand it over to Amira.
Thanks so much, Rob. Hi, everyone. It's really great to be with you today. Really appreciate the invitation to take part in this discussion with you all. I don't have a PowerPoint like Rob, so I'm going to attempt to have an extra sparkly personality this afternoon. So yes, I'm going to pick up where Rob left off. We have an opportunity, a critical opportunity in the next couple of months with this second budget reconciliation process to potentially win some critical steps forward in expanding healthcare nationally. Similarly to Public Citizen, nurses across the country have been leading the movement for Medicare for All for decades. And we have been leading that movement because, as you all know as doctors, just as well as nurses know, we're on the front lines of healthcare in this country. Our nurses are working closely with patients and their families every day in hospitals and clinics across the country. And when you work at the bedside, there is no denying the reality of our health system, which is that it doesn't work. It's not quite correct to say that our health system is broken, because actually it's a fragmented for-profit health insurance system that is designed not to guarantee healthcare, right? It's inherently designed to deny healthcare. So it's very difficult in this current system to find ways to guarantee that all patients in the country will get the care that they need, and that needs to change. Now, we don't expect to have the chance to win a full Medicare for All system during the Biden administration, but it is possible there is an opening to win significant steps to increase the number of people who will get the healthcare they need by improving the Medicare program and by lowering the eligibility age for Medicare. And there's a couple reasons why we have this opportunity. First, There has been an opening from President Biden, first during his campaign and his transition, but now there is an opening in his American Families Plan. As Rob just said, he doesn't actually, in the American Families Plan, he doesn't actually say that as a part of the plan, Medicare should negotiate drug prices and Medicare should be improved and expanded, but he creates an opening for Congress to do it. So that's one part of this opening, but we also have a political opportunity here, which is that we are hopefully coming out of this horrific pandemic during which the entire nation, but particularly seniors, have faced significant challenges. And so there is a real opportunity to build political will from members of Congress and elected officials to make improvements to Medicare that would benefit seniors and to expand Medicare to many Americans who right now can't access healthcare that they need in the midst of this pandemic because they've lost their job and they've lost their employer-sponsored insurance, or because they can no longer afford the costs of their deductibles and their copays, even if they could afford it before the pandemic. The first step to being able to do this is what Rob was just talking about, is fighting for Medicare drug negotiation. Rob laid that out really well. This is critical, as he was saying, in budget reconciliation, because it is the savings from drug price negotiation in Medicare that we can then apply through the budget reconciliation process to investing in Medicare to improve it and expand it. So winning Medicare drug price negotiations is the first step in this process. So I'm going to talk to you now more in detail about how we can improve and expand Medicare. So the first key thing is, as I think many of you understand well, the Medicare program as it exists now is good, and people over the age of 65 overwhelmingly support it. They overwhelmingly love it. Americans can't wait until they turn 65 so that they get Medicare. But it isn't perfect. And it doesn't, there are critical services that Medicare right now does not cover, primarily hearing services, dental services, and vision services. So in the US today, half of all adults over the age of 75 have hearing loss. And one third of adults age 65 to 74 have hearing loss. So that's a tremendous number of seniors suffering from hearing loss. Yet what we find is that more than 70% of older Americans who could benefit from a hearing aid don't have one, most often because hearing aids are just too expensive, with costs ranging from $1,000 to as much as $6,000 for a single hearing aid. And so this is one critical service that seniors in Medicare have consistently been saying they need to have covered. Dental, we see a similar problem. Over 70% of senior citizens have no dental insurance. The results of that are tragic for older Americans. More than a quarter of older Americans in this country are missing all of their natural teeth, with many unable to properly digest food because they can't afford dentures. Dentures can cost anywhere from $2,500 to more than $5,000. We need to cover dental services in Medicare. Vision, similarly, older Americans direly need coverage for vision services. Right now, they don't have it. So what that has meant is the fact that traditional Medicare does not cover these critical services has given this opening to private insurance companies through Medicare Advantage to lure seniors into paying into Medicare Advantage plans that quite simply just don't work very well, and that in many cases work as a scam for older Americans. So if we could cover these services in Medicare, we would see the healthcare that our older Americans are receiving would just become so much more comprehensive. So the way we would do that is that, as Rob was laying out, Medicare drug price negotiation, the numbers I've got here are that it would save somewhere up to $456 billion over the course of a decade, and it would increase revenue by $45 billion over the next decade. Dental, vision, hearing, covering those three, all three of them together under Medicare together would cost $358 billion in a 10-year budget window. Now, these are numbers from the Congressional Budget Office. They're based on HR 3, the bill that Rob was just talking about. So, they may look different. That number may look different based on the specific policy considerations that we may see in a reconciliation package. But that's our best estimate for how much it would cost to cover all three, which means we could do that and still have money left over from covering, from ensuring Medicare drug price negotiations. So that's the first step, improving Medicare. This is also important because if we want to expand Medicare, we want to make sure that when we expand Medicare, Americans coming into Medicare at a lower age are happy with what they get in Medicare, right? So if we can improve the Medicare program, that will really help us politically as we continue to try to expand it later on. Lastly, the last improvement we need to try to make in Medicare in this process is to lower the cap. So right now, senior citizens are trying to survive on less than $2,200 a month. And that does not leave a lot of room for paying out-of-pocket costs that they need to pay based on the way Medicare operates right now. We should be applying an out-of-pocket spending limit to traditional Medicare, which has already happened for Medicare Advantage plans and other private insurance plans through the ACA. That needs to happen within Medicare. So that's the way I sort of see it. Is part one is we need to win Medicare drug price negotiation and reconciliation. Part two is we need to apply savings from Medicare drug price negotiation and reconciliation to improving Medicare. And part three is expanding the Medicare age. So the Medicare program has achieved universal coverage for Americans 65 and older. The uninsured rate for adults ages 50 to 64 is 10.5%. Over the past year, Americans approaching retirement age in that age bracket, 50 to 64, have faced significant job loss as a result of the economic crisis that has been brought on by this pandemic. 27% of adults age 50 to 64 are not confident that they can afford health insurance over the next year. More than a quarter, more than 25%, report issues with navigating health insurance options, coverage decisions, and how their choices will affect their out-of-pocket costs. We need to expand Medicare to adults below the age of 65. The COVID pandemic has just shown us how important this is. If we lowered the age of Medicare to age 50, it could cover 63 million Americans. That would be 63 million Americans that we would be ensuring have guaranteed health care, adding them to the Medicare program. So from a nurse's point of view, I'm not a nurse, but I represent nurses. From a nurse point of view, from a clinician point of view, there's a lot of benefits in expanding the Medicare age down to 50. As you all know, there are numerous medical tests that start at age 50. What we see right now is that when Americans qualify for Medicare, there's a lot of research that shows that there's kind of an increase in diagnosis of health conditions after the age of 65 that could have been diagnosed much earlier if Americans had the preventive care they needed before they reached age 65 and got on Medicare. For example, there's research specifically that finds a spike in cancer diagnoses after the age of 65, right after qualifying for Medicare, cancer diagnoses that should have and could have been diagnosed much earlier. So from a clinical perspective, bringing down the Medicare age would be extraordinarily impactful in terms of improving patient care and reducing illness and preventable death. So where are we on these issues in terms of political support? I think is the big question. As Rob was saying, there is a lot of political support both public support, but also political support in the White House and amongst members of Congress for Medicare drug price negotiation. Speaker Pelosi is very supportive of Medicare drug price negotiation. We now have Senator Bernie Sanders as chairman of the Budget Committee, who plays a very critical role in this process. And he is committed to ensuring, to fighting to win Medicare drug price negotiation, improvements in Medicare, and Medicare expansion. It is not clear that we can definitely win all three of these things in in this second budget reconciliation process, but we certainly should be able to win some of them, and we need to fight hard for all three. Many people ask us why we are focusing on calling for Medicare to be expanded to age 50 instead of age 60 or age 55. For us, that decision has been twofold. First, like I said, from a nursing perspective, from a clinician perspective, there's a lot of benefits to having Medicare expanded to age 50. So that's number one. But number two, from a political perspective, it's always important to be asking for what you want, because often we don't get everything we want, right? There's some compromise. So it's really important to be building a movement calling for Medicare at age 50. At the moment, President Biden has been open to Medicare at age 60. If we're calling for age 50, that makes it a lot easier to win age 60 or age 55, right? And it makes it a lot easier to continue building the movement to win Medicare for all Americans, regardless of their age. So the timeline of this process is we're expecting a budget reconciliation process to be rolling in June and July, and potentially to wrap up before Congress breaks for the August recess. So the next month to 2 months is a really critical opportunity for doctors, for nurses, for advocates across the country to be talking with their members of Congress to explain just why Medicare drug price negotiation, putting those savings into improving Medicare and into expanding Medicare, are so critical in this moment in time. And I think for doctors and nurses alike, we currently have, there is currently so much political will in our favor because of what our professions have been through over the course of the past 15 months, right? You all, like our nurses, have been on the front lines of the COVID response in this country. And so you all, like our nurses, understand exactly how this pandemic has laid bare the failures of our current health system and the urgent need to improve our healthcare system. And the best way at the moment that we can do that in this political situation is to improve and expand Medicare in this reconciliation process. And so I think coming into any advocacy you're doing with elected officials, leading with the COVID crisis, talking about what you've seen in this crisis, talking about what you see when you are providing patient care even before the COVID crisis, it really goes a long way in helping legislators to understand why this is so critical. So I know we're over our allotted time, so I will end there and look forward to taking some questions.
Wow, thank you so much, Robert and Amira, for really so brilliantly walking us through the current climate that we're facing, and really the next steps here for us as advocates for Medicare and through budget reconciliation. I would like to invite any of the audience members, we have the rest of our time for Q&A, to please feel free to put questions in the Q&A section, and I will look to respond to those. We already have several coming through here for us that we'll explore. One of the first questions I wanted to ask, and it really kind of builds on both Amira, what you were just saying, as well as some of the points Robert had been mentioning earlier. You mentioned, that Robert, that this is going to be a tough fight with the coming up against the pharmaceutical industry. And are there hopeful signals you're seeing that we can take them on effectively? Or are there particular ways that we can help make this the movement to get this through, given what we're seeing in our clinics and our hospitals of people increasingly not able to afford the drugs we prescribe? And as Amira had mentioned, us being the front line of the COVID response in this country, to bring those narratives and those stories to the forefront to really catalyze change.
Yeah, absolutely. I think Amira hit on two key themes. One is, notwithstanding the power of the industry, a lot of the Democrats understand that they ran on this issue, including Speaker Pelosi. And they are very worried about, leaving aside the merits, let's just assume that they have good hearts on this, but leaving aside the merits, they're worried about their political futures if they don't deliver on this thing they promised. And, there are a lot of political promises which are kind of nebulous, but drug pricing is not. Either you do something or you don't. Either people can afford it or they can't. They feel it or they don't. So I think they're right to be worried. I think they should anticipate people holding them accountable, not so much that Republicans will run against them, although that is possible, talking about this issue, but that people will stay home and be disengaged, or be susceptible to other kinds of really horrible and racist appeals that we've seen from Trump and crowd, because they're not getting meaningful relief. So there's a lot of awareness about that consideration in the leadership, especially on the House side. And that's real momentum for us. And the other thing, which presumably is part of the theory of your whole advocacy efforts, is that you do bring a special voice. I mean, when we go as public citizen, we talk on behalf of our members and supporters, and as a consumer issue, we can talk about patients and how they're affected. But you wear the white coats and you go in, and the members and the senators, or their staff, but especially the senators and members, they listen to you differently, and they respect your role. They defer, maybe it's a bad idea, but they defer to some extent to your expertise, or at least perceived expertise. And when you tell them stories that come from your own clinical experience, that is super powerful. It's actually more powerful to hear, it shouldn't be, but it's more powerful to hear it from you than it is to hear it from the patients themselves. Because you both feel it, but you're also a little bit removed. You can tell this firsthand account, but you're not going to, with passion, but you're not part of the story. They just kind of absorb it better. So yeah, you guys are like the most, along with the nurses, the most important spokespeople we have. And you really, if you bring it, it makes a big difference.
Praveen, if I can just add to that, and seeing in the chat a question about, how do you expect change with the partisan divide? I think we have a really amazing win in the past month, which was the people against the pharmaceutical corporations. Public Citizen, NNU, many other organizations were working and continue to work staunchly to win a waiver from the World Trade Organization, a waiver from patents for certain COVID-19 vaccines and treatments. There's a proposal that's been made by South Africa and India, the World Trade Organization, and we have been fighting tooth and nail to get the United States government to support that waiver. That's something that many of us who've worked on access to medicines and pharmaceutical issues for many years maybe thought wasn't possible. And we succeeded. The movement succeeded in pushing the Biden administration to publicly support that waiver, despite the power of Big Pharma opposing it. So we can overcome Big Pharma's tremendous lobbying efforts, right? We know we're capable of overcoming it, and the expertise of doctors, along with the expertise of nurses together, is so critical in making that happen.
Thank you so much, Amira and Robert. We have several questions coming through, and so I'll go through several of them. One of them, to first of all, to ask is a really timely question, in that the pharmaceutical industry has seen a refurbishment of their reputation due to their involvement in bringing COVID-19 vaccines to the market. We've also seen companies stating that government regulations on prices will impact further future innovation, and they often point to COVID-19 vaccines. How does this impact efforts to address high prescription drug prices?
Yeah, it's just part of the landscape right now. I think the overall reputational thing is a little bit of a boost for them. I don't think it'll last too long. We do have a lot of data, polling data that shows that even if, although in fact, pharma's reputation is a little bit better now than it was a year plus ago, there's no diminution in people's concern about drug pricing. So that issue hasn't gone away. Of course, their story always, to justify their high prices, actually I moved away from it a little bit, but their primary story always is research and development and innovation. They moved away from it a little bit because they charge so much. It's becoming untenable to say it's all supposedly for R&D. But I don't watch TV, but I do watch, video and stuff on my computer. So that's very targeted. So I'm seeing ads that are targeted for DC, and pharma's all over the place targeting the DC audience, saying, yeah, look at this great innovation. We brought you these vaccines. It's hard to imagine the case study that shows more the importance of public investment and less the key role of drug company private investment. We've done a lot of work on this, and a bunch of people have. Coronaviruses, as you all know, didn't just start. In the 15 years prior to the outbreak of the pandemic, NIH spent virtually all the money that was spent globally on coronavirus drug and vaccine R&D. The drug companies did nothing. The platforms that they're all relying on are entirely publicly funded. The Moderna drug is 100% minus Dolly Parton's contribution, publicly funded. It's not quite as severe with the other ones, but they have we're not going to win probably that particular, unfortunately, that particular PR fight. But it's a great case study of the central role of public investment and the relatively small role in true innovation that pharma plays. They're really latecomers and running the big clinical trials and then spending money on marketing and so on. Anyway, so the core political question, it's going to hurt us a little bit. They're certainly going to lean into it heavily, but it hasn't changed the core public demand for reform. And it's certainly not changing what members of Congress are hearing. They hear about this stuff all the time. There's no member of Congress who doesn't hear about drug pricing because their constituents experience it. And there's no way to escape the problem.
Excellent. One question we have is, and it's for either of you, any discussion that you're aware of in the space for enhancing Medicare on the areas with regards to long-term care, home-based care, the lack of mental and behavioral health parity, and removing limits on physical therapy to provide those supports, which is some of the limitations of Medicare presently.
Yeah, so I would just lead by saying that the Medicare for All bill does that. So part of what made our new Medicare for All bill, which we introduced a little over 2 years ago with Congresswoman Pramila Jayapal and Congresswoman Debbie Dingell, part of what has made that bill so exciting is that it would expand Medicare to cover, under that bill, Medicare for All would cover all long-term care services and supports, including home and community-based services and supports, which is a long-standing need for communities of people with disabilities. And yeah, it's just a tremendous step forward. It would cover all mental health care services. And so, the Medicare for All bill, those are two very important angles in our advocacy around the Medicare for All bill. And I definitely encourage folks, if you haven't looked at that bill, to do so, to take a look at it, to look at the list of covered services and how it would work, because it would make massive improvements on that front. I would just say that as per my knowledge at the moment in the conversations about what we can win in budget reconciliation, those parts of Medicare expansion have been less a part of the conversation. There's been a focus on hearing, dental, and vision, but it is a part of the larger Medicare for All bill and campaigning work happening.
Excellent. We have a question. Robert, you showed the data from Open Secrets on lobbying and campaign spending on the amount of lobbying from pharma. Do you find this is a convincing data point in discussions with MOCs? Is it convincing with persuadables in the political spectrum?
No, I wouldn't talk about that. It's just so you know what's going on. I mean, I think the effective advocacy is to make the case for the need for reform. The most valuable thing you bring is to say you see patients suffering and rationing their medicines. So you understand the impact. If you want to throw data at them, I think it's about the rationing. It's about the cross-country comparisons, which are just nuts, and make it really clear that we're spending, by any measure, we're spending way too much. It's a fact that there's a lot of political power on the other side, but I don't think that's something you want to sort of really elevate for them. They get it. No, most of the members are getting a lot of visits from drug company lobbyists. There's a lot more lobbyists than there are members of Congress.
This point had come up, I know previously in the Doctors for America Medicare for All book club session as well with Abdul El Sayed and Micah Johnson earlier, the DFA hosted last month. But it was a question that some healthcare providers are talking about is, to what extent should medical professionals be willing to take any price cuts to expand healthcare, Medicare for all? I know this is there's a lot of myths out there that we're working to debunk and reframe. And so, any thoughts on that for providers?
Well, I would love to just dive in for a quick sec on how payments would work under the Medicare for All bill that we have in the House, because I think it's really important to just clarify what that would look like. So under the Medicare for All bill in the House, Medicare would pay institutional providers through global budgets, which we've seen work incredibly well in Taiwan and Canada and other countries with single payer systems. This is really important. So what I'm about to say applies to medical professionals working in institutions, working in hospitals or other institutional providers. A hospital would make a request to the Medicare program for what their global budget should be for an entire year. And what's really incredible about this bill, and I really encourage you to go look at the bill, section 611, go read it, it's great, is that it would, in coming up with their budget for the year, they would have to look at a whole variety of factors. So they'd be looking at changes in patient mix, potential changes in patient mix, overall use of different services and different units. They'd be looking at the staffing that not just the staffing that they have, but staffing up to safe staffing levels, which is really important. And so an institutional provider would be getting a global budget based on that proposal and negotiations with the Medicare program that would be paid out quarterly throughout the year. There's some important things here. One, I want to highlight the safe staffing portion. For registered nurses, we are understaffed across the country constantly. Staffing registered nurses at mandatory minimum nurse to patient ratios, which is what's written in this bill, would have an unbelievable impact on the nursing profession in hospitals. There is also language in there to ensure safe staffing for all other healthcare professionals. Just we don't have scientifically determined ratios for what that should be. So that's not noted. So number one, staffing would increase at every hospital in the country. That would be hugely beneficial. Number two, hospitals would be banned from using any money from the Medicare program for union busting consultants. This is major because for many healthcare professionals, they have been inhibited from negotiating up their salaries. We've got nurses across the country making poverty wages because they haven't been able to unionize because of strong union busting happening in their hospitals. Hospitals no longer could do this. And very importantly, for physicians working in a hospital, the hospital would be laying out in their budget request the salaries they'd be paying for their physicians. So that it wouldn't be Medicare saying we're not paying, we're paying this much for this type of specialist, right? That's not happening. The hospitals are deciding this. So it is it is a myth to say that doctors across the board or specialists across the board are going to be making less under this program. It is true, though, that many healthcare professionals will actually see an increase likely in what they're making, and also will see health and safety protections in the workplace because of this bill. And I realize we're short on time. I could talk about this section and go into details for ages, and happy to do that with any of you if you'd like, but you should check out section 611 of the bill.
Thank you, Amira. And this is we're running short on time, but I'll leave with this last question here for either of you. Are there any particular key targets in Congress that we need to be especially focused on right now, and for all our audience members as we're really thinking about next steps? And I'll bring this back home after you both share your thoughts.
I can jump in.
Go ahead, Amira.
I would say continuing to put pressure on leadership, on Democratic leadership in both the House and the Senate, even though they've especially on drug price negotiation, they're there. Continuing to put that pressure on is important. Number two, the committee chairs, leadership of important committees who will be writing the reconciliation packages are really important. So Richie Neal, who heads the Ways and Means Committee, Frank Pallone, who heads the Energy and Commerce Committee, really important. Senator Wyden, Senate Finance Committee, really important. I would note Senator Menendez from New Jersey gets a lot of money from pharma and seemingly could potentially disrupt Democratic consensus on drug price negotiation. He's a very good target. So I'd say leadership of the Dems, both House and Senate, leadership of key committees. Menendez is one important target, but also talking to your representatives is really important. They work for you, you elect them. So going to your representative, no matter who they are, going to your senator, no matter who they are, is really important.
Yeah, that's all right. I guess the only thing to add to it is things shake out, we're going to see who's wavering among the Democrats. It's a little bit early to see that. You know, on a lot of the issues that we work on a broad set of things. You know, in the House or in the Senate, there's a set of, self-defined moderates. That's the first place that we're going to look. But this issue doesn't exactly cut that way. A lot of the moderates are going to be good on this, and a lot of people who are perceived to be more liberal or progressive they may have like a biotech company in their backyard or whatever. So it'll get flushed out in the next weeks and maybe months who the really vulnerable ones are, and it's going to be tough because it's such a small margin on both sides that if a small number of the Democrats walk away, we're not going to win it no matter what the leadership wants. So we have to do all of these things. And what's cool about this call is, and I think the membership overall of DFA is, you're so geographically spread out. It's a huge asset for advocacy, to not everybody come from New York and California. Although New York is actually important too, because Schumer needs to hear. But that geographical diversity is a real strength that you should lean into.
Excellent. Thank you so much, Amira and Robert, and really thank you for everyone again for joining. As I mentioned, my name is Praveen Raghunathan. I'm a pediatrician on the National Steering Committee for Doctors of America's Drug Affordability Action Team. We really welcome your participation and your involvement in this movement and in this effort. There's so much to do, and I really am so grateful for Robert Weissman, our President of Public Citizen, and Amira Sakura, lead legislative advocate of National Nurses United, for taking their time to be with us today and walk us through these next steps for Medicare and for budget reconciliation and the work that we have to do. As a reminder, this was really a background session for us to start to get into the arena and really build on the work as was outlined for this summer. And so your narratives and stories on the front lines are such powerful weapons to really bring to our members of Congress, to let them hear from your perspectives on the front lines. And so we really would empower you to follow up from this session, to take action. Please be on the lookout for follow-up emails from DFA with next steps on how to join the Drug Affordability Action Team or the Health for all team in advocating on behalf of our patients with policymakers. This event will be available for viewing later on DFA's YouTube channel, and we will send all registrants the link as well when it's ready to watch again. And finally, to just wrap up with a few other DFA announcements and updates, please remember to follow us on Twitter, LinkedIn, or Facebook to stay up to date with all of our DFA programs, events, and ways to get engaged. You can check out our events page on our website, and it's also, we have the link there in the chat, including tomorrow's evening's live stream event. You can register for any of our events on the events page on the website. Tomorrow, May 20th, is International Clinical Trials Day, and we're celebrating with an evening live stream 8 p.m. Eastern Time session where we'll hear from Doctors Without Borders and Universities Allied for Essential Medicines, both incredible organizations about efforts to protect patients through clinical trials transparency. And on Thursday, June 10th at 1 p.m. and 8 p.m. Eastern Times, having two available times to really help accommodate healthcare providers' busy schedules. We will have our next advocacy grand rounds on policy resources and talking to legislators. And so if you can, please also take 2 minutes to complete the survey that's in the chat, and we'll continue to bring you content you want for advocacy training and opportunities. And so we, again, thank you all so much for your time today, and wishing you a wonderful rest of your Wednesday. Thanks, everyone.